Yeah, there are a lot of new things presented here at ASCO 2015. I think the newest thing is this very small study by University of Pennsylvania and Carl June's group. They have used the CAR T-cell therapy. So you take out lymphocytes and you manipulate them and give back to the same person. And they have given that to 5 patients. We have not yet heard the presentation right now. I've only read the abstract and I think they presented it on Tuesday. But per the abstract, the first patient they described had a longer benefit from the autologous stem cell transplant with the T-cells, the CAR T-cells, compared to the first time this very patient was treated with an autologous stem cell transplant in the past. So that's promising, and they also say that this patient reached a complete response and also was MRD negative. The second patient they report in this abstract reaches also MRD negative. The third patient, per the abstract, progressed, I think, in 43 or so days. So 3 patients, 2 of them reach MRD and 1 progresses using a completely new therapy in this disease. So that's exciting. We obviously need larger series and we need more information. Also here at the meeting, I think for myeloma, new things are focusing on the monoclonal antibodies, which is another new thing in the myeloma field. Per the abstract, elotuzumab study in combination with Revlimid dexamethasone versus Revlimid dexamethasone alone shows that with the addition of elotuzumab, there is a 30% lower progression-free survival if you have the lack of the drug. So the elotuzumab prolongs progression-free survival by 30%. Also there is update on daratumumab, but that abstract is not available because that was one of the late-breaking abstracts. So that's kind of a cool abstract, but we have not yet seen it, so we're waiting to hear the presentation. And also there is a lot of data here actually for myeloma. There is an update from the CLGB study for the maintenance therapy with Revlimid, and they continue to show progression-free and overall survival benefit. There's an update on the first trial that we heard from Thierry Facon a couple of ASHs ago, and showing that continuous Revlimid dexamethasone is better than shorter Revlimid dexamethasone in patients that are not transplant eligible. There is an update also from the ASPIRE trial that recently came out in the New England Journal that Keith Stewart was the first author on. And then also there is update on Feridac, the new HDAC inhibitor. There are 3 presentations on that drug. What else? There are studies looking into consolidation beyond autologous stem cell transplant. There are a lot of pieces here, so some completely new things and updates on some things we have heard about. So overall, it's a very exciting meeting. I am a very positive person, but I would like to emphasize that this is the most exciting time in myeloma ever. Up to the turn of the century, there were virtually no drugs developed. From the turn of the century up to now, there have been like 1 drug every other year or so approved. In this year, I think there will be 4 drugs approved for this disease. So that tells you how much is going on. And these are very good drugs. So I think my projection is that survival is going to double and triple one more time for myeloma. I also think that with these new drugs being so efficacious and much less toxic than the old drugs, I think for the first time, patients that are older can now be treated appropriately. So that's going to be a huge thing. I also think that the whole paradigm of therapy will change. I think the time when you start therapy, in my personal opinion, is going to be earlier than we previously did when we look for symptoms. It's going to be earlier initiation of therapy. I also think that the paradigm of treating is going to change in terms of how you treat and when you stop therapy. So it used to be you start when the patient was sick and gave us a defined number of cycles. I think we're going to start earlier and we're going to look and see what the response is, and it's going to be more biomarker driven therapy. So if you have a good response with fewer cycles or it takes more cycles, that's going to guide the therapy. And that takes me to the role of minimal residual disease detection that we have been working on a lot. I think that will potentially be a way to monitor if the patient could go off therapy or stay on a low dose therapy, and if that turns into positivity, that maybe the therapy could be increased in intensity to prevent the disease from actually progressing. So it's a kind of a functional cure, if you want, unless we can deplete the disease and cure myeloma, which I really hope and I think it's possible for some patients in the near future.